Yeah, thank you everybody for coming to the annual caregiver training for KABC. Today we are going to feature a couple of people. First up, we have Camille Russell, ombuds for older adults in Kansas. And Camille, I will just let you go ahead and introduce yourself.
Well, thank you, and thank you for having me. It's good to be here. I am Camille Russell. I am the State Long-Term Care Ombudsman. I am new to that role as being the State Ombudsman. I was appointed by the governor and the Senate early this year. I am not new to being an ombudsman. I have been an ombudsman with the program now for 5 years, and I actually identified this as a job I really wanted to do as one of my later jobs. Way back years ago, I worked for the Attorney General's office, and I was the Abuse, Neglect, Exploitation Director there for Attorney General Morris and Attorney General Six. And I identified this program then as one of having great value and that I wanted to work in. So I was kind of happy to get to do that 2015, and then stepping into this role this year. So I'm happy to be here. If you want to just go on, an ombudsman. So one of the most difficult things about being an ombudsman is learning how to pronounce that word, ombudsman. We tell people sometimes when they're applying for the job, that's the first test. If you can say the word in Swedish, that does mean to speak on behalf of another. And you will often have us when we come into a nursing home. The first thing we will say is like, I am an ombudsman. Do you know what that is? My name is, and I'm an ombudsman. Do you know what that is? Because most people honestly don't know what ombudsmen are. Ombudsman programs have been around for centuries, literally. Ombudsman was used to go out. The kings would send the ombudsman out to make sure that their tax collectors were, they said to make sure that the tax collectors were being fair, but in reality, I imagine it was to make sure that the tax collectors were not collecting extra money that they were putting in their pocket. And so anyway, but for this program, some ombudsmen are neutral and they are mediators. For the long-term care ombudsman that for nursing homes and other adult care facilities and homes, this is an advocate ombudsman. So advocacy sometimes means that we can sometimes be a little bit adversarial with others who do not agree with the stance of the person that we are representing. And so sometimes people get a little frustrated with us. I've had a few of those calls this morning from attorneys and guardians and things that are a little frustrated because we are the advocate for the resident. We are resident directed. And we just simply support that resident's right to have control over their own life. If you want to go on to the next slide. Little history is that the Ombudsman program is, depending on how old you may be, you may consider it to have been a long-term program or not very old. And I look at it and think, well, gosh, it really hasn't been around that long. It's just been since 1972. Other people might see 72 and think that was a long time. And that's just people have different perceptions. And just like ombudsmen do all the time, we are always looking at what the person's thoughts are and perceptions. But the history of us is that we were put together and when addressing a lot of nursing home issues. And so there was demonstration projects, and we have evolved now into being supported through the Older Americans Act. And in every state, there is a long-term care ombudsman, state ombudsman, including, in addition to the 50 states, also Puerto Rico, Guam, and Washington, D.C. And so there are 53 of us state ombudsmen, and we do get together frequently and talk about the issues across our country in long-term care. I found that to be very valuable. If you want to go on. It's probably important where we start is that what we are not. And that we are not regulators. We are not the people who license adult care homes. We are not the people who investigate for legal reasons, do the investigations for that purpose. We are not adult protective services. So we are not the people that make findings again for legal purposes for the registry for abuse, neglect, or exploitation. And we do not provide direct care to residents. So those three things we need to be always in the back of our mind. That's not who we are. I'm going to go on, Claire. Thank you. However, there is some confusion because we say we do investigate concerns and complaints made by or on behalf of residents. And that's true. We do. It's just that our standards for what we look at and whether or not it is the end result is accomplished is directed by the resident. So we will sometimes be looking at an abuse, neglect, exploitation type issue. Sometimes we might be looking at something that KDEDS is looking at. We have to be careful. We don't want to get in their way, but our goal is to look at that issue and to try and resolve that issue based on solely what the residents' outcomes are. So they get to decide whether or not we have been successful or not. And a lot of times that success depends on others that we can't control, but we will do our very best to try and resolve issues for the resident and or their representative. The resident's not able to tell us. But again, we always have to go to the resident first. We, again, are not a substantiator for legal remedies. So what happens is the resident guides all of our actions, that we always look at their residents' wishes. It does not always have to be a popular thing. It does not always have to be, you know, what we agree with. That's something very important. It doesn't really matter what we personally agree with. It is what the resident is wishing, and then we will advocate for that as long as it's legal, and we are going to advocate for that. Again, we're going to try and resolve it to their satisfaction. We are at all times wanting to promote what really, quite frankly, is regulation, is that they have choice and control over their own lives and that they have rights. So we will always represent them in their rights, and we will never share information without their consent. We do not advocate for people in independent living. We do only do nursing facilities that are federally licensed, and then we do adult care facilities such as assisted livings, board and care, home pluses. I always leave out some of them as I try and make the list in my head, which is why I should list it, but we do not do independent living, and we do not do nursing homes for mental health either. I'm going to go to the next slide. Thank you. Other charges that are in the Older Americans Act and other legislation that we are charged with doing is that we provide technical support for resident and family councils. Probably that is one of the most important things that we can do, because who are the best advocates for people? Themselves. They know themselves, they know what they want, and they're right on site to be able to do that, so that we can help build resident councils and that they can with each other help each other with their advocacy. That's probably the best empowerment that we can do. And next to that are family councils, because by choice, family by choice, whether they are actually related or not, that they are the next best advocates as people that know them and love them. So that is another charge that we have. I'm trying to watch the chat, which I probably should just quit doing. Sorry about that. But in all ways, we do advocate for changes to improve residents' quality of life. And so when I say that, that could be individually or collectively. And I may get into that just a little bit more later as we talk about things we see in resident rights in general. So whether or not it says provide information to residents and others. So we may get calls from residents, from their family members, from a neighbor that they used to know 10 years ago that heard they're in a nursing home, from staff, from the regulators themselves. Sometimes will let us know we were in a building and we think it might be good, you know, so-and-so said they would like to talk to you. Then we will make sure that we do that. So we can get calls from any place. We will provide information and assistance per their request to anyone. We will not talk about a specific case or a specific issue without the resident's consent. And we do. So individuals, there are many individuals. I had a question in the chat. It was about advocating for dementia residents. Absolutely. Residents with dementia are humans just the same as us, that they have the rights. They can still express their wishes. And we absolutely, all residents, all people are people. And so whether they have a diagnosis with dementia or not, we absolutely do advocate for their wishes. Sometimes we do have individuals whose cognitive abilities or physical situation is that their communication is more limited or is a little harder. And so we work very hard to determine what their wishes are. I know we have had individuals, I remember one time we had three brothers who thought that their mother all needed to be in three that didn't agree where she should be in that 3 different places. She absolutely had her communication. I was very limited by that point. literally she did it, she would tap with a finger. And there was a certain tap for yes and a certain tap for no. And it took multiple visits. And fortunately, one thing that was handy with her is she had been an owner of a nursing home. So she knew who an ombudsman was. So it was very helpful for her to know that we would indeed listen to her, her nonverbal communication, and that we would honor her wishes, and that we would spend some time to try and really vet what those were through yes and no questions, which is interesting to do over a period of time. But we will always honor their wishes, and we will always do our best to figure out how to communicate at the level that they can, and whether it's verbal or nonverbal. So I'm gonna wait on some of these questions till the end so we can kind of stay on track, and I want to answer all of the questions though, okay? So put those questions in the chat and we'll keep going. So we'll provide information as we're contacted about. We talked about, yeah, you can go to the next one. There we go. Other responsibilities are that we represent resident interests before governmental agencies. So I meet with legislators, meet with the regulatory folks, and we say, look, this is what residents tell us. And we advocate for what we are being told. We've been doing that quite a bit with visitation this last year. Seek legal, administrative, and other remedies. We oftentimes are looking at trying to build capacity. We've had quite a bit of conversation here lately with multiple entities trying to build capacity with regard to involuntary discharges, and linking people to the legal resources that they need to have help with their issues. Ensuring residents have regular and timely access. What that means is that we make visits to nursing homes. And during the pandemic, we were kept out for a few months, but we are back in there. And we make regular visits to without a complaint. We visit all nursing facilities at least quarterly. And then we also try to do that with the assisted living and boarding, the other adult care licensed by the state. There are almost 750 facilities that we are charged with visiting and providing access to, and there are only 7 regional ombudsmen. So be patient with us. We will do our best, but sometimes we can't get out there as fast as someone would hope that we could. You could go on to the next slide. So one thing that we really work on is that residents have rights. They have all of the same rights that you or I do living in the larger community, but just because their address happens to be that of an adult care home does not mean they lose rights. They actually have some additional specific rights. And so if you're in a federally licensed nursing home, those are federal rights that are outlined very broad, very in much detail. If you are in an adult care home that is state licensed, we also have state regulation that covers resident rights, and it is listed here. The regulation is 2639-103, and it starts out by saying, and we have to talk to administrators quite often about this, operators about this quite often, that it's their job to actually protect and promote these rights. And so we may get into that as I go through some of these rights. I may tell you a story or two about things that occur. If you want to go to the next slide. There you go. There you go. Dignity and respect. I often talk to people, whether it be the regulatory agency, KDADS, that does the licensing and investigations for legal purposes. Often talk to them. It's like, and also CMS, that's the Centers for Medicaid, Medicare, that's the federal entity. So when we're talking to those folks, whether we're doing that on a local, state level, or whether we're doing it at a federal level, we often tell them as ombudsmen, it's like, instead of your hundreds and hundreds and hundreds of pages that everyone has to dig through, if we actually boiled everything down to, are we taking this person's choices into consideration, preferences into consideration? Are we treating them with respect and dignity? If we boiled it down to that answer right there, we probably could get rid of all the other regulations. But oftentimes what is thought of in these areas that comes to mind is that, and a big one, as simple as knocking at the door. No one comes to your house, or shouldn't really probably come to your house and just without pre-arrangements, if that's okay, and just barge in your room. And yet, how often we see that people maybe take the time to knock in a nursing home's room or adult care home's room, but they just walk right on in. They don't even wait for the person to answer and let them know whether or not that is okay or not okay. We often use that as a tip. We often tell the staff that are working in a home, it's like, they'll say to us like, well, I don't know, I don't understand. They tell you things they don't tell us. And it's like, because we start from the very beginning and we remain respectful and treat people with dignity. And when you do that, you build trust, and they do come to you for what they need. And then you can help them with what they need. And it starts from the very first interaction that you ever have. So when I have and it doesn't happen very often, but I had a woman that the facility kept wanting me to come and talk to her. And I would knock on the door and she would say, no, I don't want to talk to you. I'm like, okay. And I had started with, I'm an ombudsman. Do you know what that is? Nope. And I told her. And nope, she didn't want to talk to me. I'm like, all right. And I said, would it be okay with you if I would just leave this brochure with you? And then if you ever did want to talk to me, you could do that. Yeah, she let me do that. Okay. I got to leave the brochure, but I treated her choice with respect. She said no. The next time I was in the building, of course, they wanted me to talk to her, try to talk to her again. I knocked on the door. I said, I'm the ombudsman. I don't know if you remember me. Yep. I'm like, I just wanted to stop by and see if there was anything. Nope. I'm like, all right. I said, do you still have my brochure? I can give you another one. She didn't answer me. I said, I won't bother you anymore. And I walked off. But I did get a call from her. She had kept my brochure that I had written my cell phone number on, not just the 800 number, but my cell phone. She called me on my cell phone. And the woman called me on my cell phone because she had been left in the bathroom. She was currently in the bathroom and she could not get anyone to come and answer the call light to help her. And she said, can you help me now? And I said, with your permission, I will call someone in the building and have them come right there to help you. And she said, okay. And so I did have the cell phone to the administrator and I got a hold of him and I said, I'm just going to stay on the phone while you get somebody to go help her. And they did. Now I can tell you that the woman talked to me every single time I went into that building after that. But it started with me allowing her to say no and respecting that choice. Dignity and respect. So we'll keep going. Oftentimes we see that we have problems with that, with people posting pictures they shouldn't post of people, with not helping them with, you go in and they have not helped them with their hygiene, those kind of things. You see those things cited a lot of times. But when people think about dignity and respect, it has more to do with whether or not staff are smiling at them and fulfilling their wishes versus rolling their eyes or sighing.
Camille, we do have a question. Would you like to answer it now, or would you like to wait to the end?
You can ask me. Go ahead.
Okay, so the question is, how does an ombudsman ensure a legal, parentheses, court-ordered guardian's decision on behalf of the ward is executed even if the ward verbally expresses a different choice and the ward lacks capacity under law to make that decision, and that's why the guardian is there?
We actually do have that quite a bit. And so we try to spend time helping the guardians understand that state law says that guardian will make decisions. They will include the person in their decisions to the extent that they are able. So if the person is expressing a wish to us, and they can tell us that, then we try and help them communicate with the guardian that that is their wish. Now, it's not as simple as that just happens, right? But it is important for everyone to understand that even under a guardianship, people have a right to access their ombudsman, and that ombudsmen have the hat that they wear, that they will try and advocate for what that person's expressed wishes are. So it may be that the person says they want a particular thing. What is important is that we figure out what it is they They do. We want to listen what it is they really want, what they're missing, and how can we support them? How can we support them in having that, or as close to that as possible? There is dignity and risk, and we need to understand that they do have that right. They have that right to respect and dignity, and that there is dignity and risk. I had a conversation this morning, and one of the things that was said is like, if they don't live in a nursing home, they won't take their medications. And I said, well, they have a right to refuse their medications in a nursing home. That's another right, by the way, the right to refuse. And a guardian can't impose and make a facility make a person take their medications. And so what we do is we want to make sure that we're informing the people. People will make better choices for themselves if they are treated with dignity and respect, if we honor the things important to them. So if we think about their relationships that are important to them, we think about the things they want to have, the things to do, their rituals and routines, all of the things that you and I find are important to us. And we find a way to support those, we find that they make better decisions about things that are important for them, those health and safety things that guardians are usually very worried about, and in fact charged with trying to make sure are in place. So we have to respect that the guardian is doing their job, and we ask that guardians respect that we are going to try and advocate for that person to have the things that are important to them and balance the health and safety risks. It's actually part of the final rule for home and community-based services. Anyone that's on Medicaid that is in adult care setting, in an assisted living or boarding care, there's a final rule that says that it's actually a requirement that we do that. And state law for guardians say that they will honor to the extent able and to the extent that persons express their wishes, what they want, and have them do as much as they can. So it is kind of hard. It's hard sometimes, and sometimes we actually do get into a little bit of an adversarial situation until we can learn to communicate about, well, look, we really both have the person's best interest at heart. We do have to advocate for their wishes. Maybe we can figure out how to make it happy, everyone happy. Do our best to do that. So free from abuse, neglect, and exploitation, I might say that we even have a role. So if indeed someone tells us, I do not want to live in a restricted setting, I want to live in a less restricted setting, and the guardian is fearful of that, and oftentimes it is usually based on fear that they will not be safe. We have an obligation, we have an actual obligation to at least look at what sort of planning could be done to allow that less restrictive placement. And so that's one that happens a lot. Being free from abuse, neglect, or exploitation. And actually the regulation actually says that that is the resident and their family is protected, like from derogatory remarks, that's abuse. Threats, like they won't get to see their family. We oftentimes will talk to the administrator, sometimes will say things like, you won't be able to live here if, or wouldn't you be happier somewhere else? And we have to talk to them about, that actually could be looked at as a threat to not have a place to live. And that would be abusive. That is emotionally abusive to someone. So we do talk to them about how we talk to people and what we say. And then we all recognize, I think most of us recognize physical abuse, the actual neglect, serious neglect, and exploitation where people are taking advantage of people for their own personal gain. But sometimes there's more subtle abuse, neglect, and exploitation. And they have a right to be free from those things too, that we do sometimes address. They tell us those subtle things that they may not realize they had a right to. Nursing homes will contact us about the person wanting to work. They want to do their own laundry. Well, how can we make that happen? Not only will it relieve some work from your staff, but guess what? They probably will get their own clothes back in their closets, which comes to the next right, which is security of possessions. And oftentimes we find that people are losing their items. And the home's responsible for security of possessions, and they're responsible for helping replace things that are lost or damaged, including dentures, including hearing aids, including all sorts of things that they will try and say that they are not responsible for. But indeed, people have a right to security and possessions. They should help the person if the person wants to keep a sum of money in their room. They also can keep it for them if the person chooses to do that. But if they want to keep a sum of money in their room, and they need to help them with a way to have that locked up and safe, if they choose to do that. There's so many things that like 3 words does not even become close to all of the things that fall under these that is hard to imagine. And what I always tell people is like, well, how does it work at your house? Do you have the freedom to decide this or not? And how does it work at your house? Because that's how we're going to advocate for this person. Again, just because their address is that of a licensed home doesn't mean they have less rights or fewer rights. In fact, they have these more specific rights. Freedom from physical or chemical restraints. Things we see sometimes is that people are asked to be medicated and they have a right to refuse that. They're asked to take medications to inhibit their ability to move as well. They're over-medicated, abused. It's abuse. It is abuse sometimes. And or physical restraints. We love our recliners. I love my recliner. But if I am put in a recliner where I cannot get out of my recliner and no one is there to respond to me, they do not respond to me when I ask to be helped up, then it's a restraint. And they can't do that. Bed rails. A lot of places used to use bed rails a lot as a restraint so people wouldn't fall. Well, there's other ways to make people safe if they are falling out of bed. But there is research to show that bed rails actually are more dangerous than not having bed rails because there's other ways to address it. Now, on the other side of that is sometimes people want a bed rail. They want it to be able to grab onto. They cognitively know that that's what they're going to do with that. And they can grab on that bed rail and it helps them set up. So we have places like, no, we can't have bed rails because those are restraints. It's like, well, they're not in that for that purpose. And so write your care plan, write your plan of care or your service plan. That is why you have whatever it is that you have. It is the person's preference. It is for their benefit. And write your plan well. And so then you should be able to have it. Again, not to keep them from falling out of bed, though. There's other ways to do that. So that would be a restraint if you were only doing it for that purpose. Couples have the right to share a room as they choose. And that is whether they're married or not. And it is whether they're the same sex or not. And it is whether or not their daughter or their son or their uncle or whoever thinks it's okay. It is their right to choose that. So that is one we do get a lot. And it is difficult sometimes, but they do have that right. If you want to go to the next slide. To manage their financial affairs. We get a lot where people contact and say, well, they said we have to allow them to be the payee, their representative payee for their Social Security. It's like, no, you can't require that. They have a right to manage their financial affairs. And individually, they have a right to manage their financial affairs. So for whatever means that might be, they just have the right. Stimulus checks were a big thing this year that places tried to take their stimulus checks, and that was fought at many different levels and taken care of. But they have a right to make those choices, good or bad, just like you or I. They have a right to make choices about their financial affairs. They may also have consequences of that. They manage to have a credit card and they only have a certain amount of income. There may be a consequence of that, but that's between them and their credit card company. And it is not our place to prevent that or take their credit card from them. We want to help educate them. All of us would want to help educate them on their options and their possible risks. And then they have a right to make their choices. Participating in their individual care plan or the negotiated service agreement. They have a right, not only do they have a right to participate in it, but they actually have the right to guide it and be the primary goal setter for that plan. in choosing physician, pharmacy, or other provider. One that has come up recently a lot, unfortunately, has been hospice. They can't be made to use a particular hospice. If the place that they're living in does not have a contract with that hospice provider, they need to work out a way for them to be able to have one. And so that is one thing. A physician, and one thing that's important to know is that while they have a right to choose the physician, a physician does have the right to choose not to have them as a patient or client. So sometimes that becomes an issue where they're like, well, I want so-and-so, and that doctor refuses. So if they won't follow the doctor's orders, a doctor sometimes will not continue to be their doctor. And that's a risk. That's a right they have to make a choice about whether they follow doctor's orders or not. And then it is the doctor's choice whether to continue to treat them. And most of them do, but there are times when doctors choose to no longer be a doctor. More so, they choose not to accept a new client. Leaving them without a physician wouldn't be okay. Pharmacy, places like you to use the same pharmacy that they use, but you do not have to do that. There are some exceptions to that in long-term care units in a hospital. The same with the doctor. They can limit you to physicians who are licensed for that hospital. That's a kind of a rare exception for that right to self-determination. Self-administration of medication. They really like to provide the medications themselves and let their med aides provide all the medication and keep that all there. But you have a right to self-administer your medication if you show you can do that in a safe manner. The assessment's fairly easy. I had one woman one time that was upset that she said, I can do it and they won't let me. And she had some other issues that she wanted me there for, but her sister was there too. And the med aide interrupted our visit, which again, happens. It seems like they interrupt when the ombudsman's there quite a bit, and we have to talk to them about dignity and respect and confidentiality and privacy and all kinds of rights. But in this case, the person said, "Oh, I'll go ahead and take my medication. I'll go ahead and take my meds." And I did kind of. I think I actually took a little liberty because I had not known this resident very well, but because of some of the other things she was wanting to have addressed, I said to her, I said, I'm curious. And she'd already talked about wanting to take her own medicines. So I did it in front of the med aide. I said, I'm curious. I said, do you know what all those pills are for and why you take them? And she says, oh, yes. And she took the little cup from the med aide's hand and she started through her pills. And she had 11 pills. And she named this pill and she said what it was and what she took it for. And she took her pill. And then she took a couple more and she says, these are for this. And she took her pills. She got down to the 11th and last pill and she stared at it. And she stared at it. And I can remember silently thinking, oh, you only have one more. Come on. I mean, I was just cheering for her to be able to say what that was and what it was for. Now, to this day, I do not know if she didn't know what it was and what it was for, or if she really just wanted to be ornery. But that last pill, she looked at so long. She looked at it, and the woman was 84 years old, and she said, and this one is my birth control pill. And I love it. I just loved that she did that. I always wanted to know if she really couldn't remember that last pill and she put it to last hoping she would, or and that was her way to cover it, or whether she was just being kind of ornery and not realizing that she was kind of sort of doing a medication assessment at the point in time. She did, by the way, just for your purposes, know that she did get a lockbox for her medications and she did self-administer her medications ongoing. So anyway, that is one of your rights to self-determination. To request, refuse, or discontinue treatment. Always have the option of not doing what our doctor tells us. I had someone tell me this morning, and it was a guardian, and they said, well, if they lived in an apartment, they wouldn't take their medications. And I said, well, that could be. I live in an apartment. Sometimes I forget to take mine too. So it could happen. You're right. But they do have that right, and they have a right to literally refuse to do what a doctor's order, quote unquote, order is not a law.
Yeah, it looks like,
and we do try and explain to people why the doctor, and go ahead. Oh,
I
we do try and explain.
Go ahead.
Am I okay now?
Yeah, it was just freezing up a little bit. So
okay, all right. A doctor's order is just that. It is a doctor's order. It is not the law, and people have the right to choose to follow it or not. And that is not a reason. That's not an appropriate reason to threaten to discharge someone because they're not following their doctor's orders. We sometimes have them say those things, but it's not an appropriate reason to do that. So just know that. Refuse experimental research. I will be honest with you. So far, haven't had that case to deal with. Sure I will. We keep doing this long enough. Sure I will. But they have a right to refuse that, to participate in community activities or not. That would be internal and external activities, by the way. So they just simply have a right to choose whether they do those things or not. Any kind of personal decisions, they have a right. They just have that right to choose. So using the bathroom when needed, I see this come up. Absolutely. And this is probably one of the hardest ones. Look, there is not enough staffing. This last year is the first time that we've got them to admit they do not have enough staff. And what has happened is there has been a really, really, really slow evolution where there is some sort of crazy acceptance that not having enough staff is an okay excuse to make for not helping someone get up and use the restroom when they need it, and that they will actually brag to us about, look, we get our call lights answered within 7 to 10 minutes. And it's like, really? When you get up in the morning, does somebody make you stay in bed 7 to 10 minutes? And are you on some sort of medication like, the Lasix or something that it is just amazing to me that anyone thinks that is okay. And what we know is 7 to 10 minutes is something they brag about. What we are seeing is it's more like 20 minutes is a good time in most places. Or literally they tell people, oh, there's a pad on your bed. Go ahead and use the restroom. We'll clean it up in a little bit. That dignity, respect, neglect. No, none of that is okay. None of that is okay. So if you want to go to the next slide. The right to be fully informed. Everything I've talked about these rights. It's like really educating. I say educating, but really making sure people have the information. You and I make decisions every day based on we need information to make good decisions. So we need to make sure that the people that are making their own decisions, living at an address that happens to be an adult care home, also have the information they need to make good decisions. And a lot of times it's confusing stuff that they have to decide about. I kind of like to have somebody else I talk to about my health status and what the doctor said. I like to have actually someone else there to know what it is, in the moment they said to me, and then what my choices were, and be able to ask other questions that I didn't think of at the moment. And so they have a right to be fully informed and in a language that they can understand. I had someone call one time, probably more than once, but I can think of this time that they called and they're like, well, they were upset because the person was talking in Spanish. And like, well, I've told her she can't do that. I'm like, well, really, you can't tell her not to do that. And who do you have there that can use her preferred language, that what she understands, so that she knows what's going on? She goes, oh, well, my aides talk Spanish, and she was just really upset that the person and the aides did have a good relationship because, of course, they could communicate well with each other, but the operator didn't know what they were saying, and that was bothering her. And it's like, don't know what to tell you. I mean, you're someone there needs to translate for you, or perhaps you could learn Spanish. But she has a right to use the language of her choice and be informed in that language as well. So. But all of these things that all about any treatments that are going to happen, to be informed of. I don't know how many times, you would walk into a home and someone was sitting up front waiting for a ride they'd gotten ready for, that someone else had canceled their appointment and not told them. Or perhaps worse, that they came to get them for an appointment that they didn't know about. And had they known, they really would have wanted to wear something different that they had on. They would have wanted to had a bath that morning. Different things like that. Dignity and respect, right? Communication, be fully informed. So everyone has the right to have all the rules and regulations available to them and have a written copy of the resident rights. Now, sometimes we talk to the regulators about, just because they have a copy in writing of the resident rights doesn't mean that they fully have been made aware of what those mean. And an operator administrator has an obligation, the home has an obligation to help them understand what those rights mean as well. They have a right to know in advance about changes in roommates and some choice in that matter as well. More so in adult care homes, we don't have, in state licensed homes, we don't have as many where people are sharing a room as we do in nursing facilities, federally licensed nursing facilities, but they still have that right to know about change in roommates if they do have one, or to have a roommate if they wish one. So you can go to the next. That right to privacy really just in all matters, just privacy, period. So when someone's adult son shows up out front and they're not allowing people to come inside to visit, but he has an envelope that he wants delivered to his mom for his mom to see and read. And somebody comes back outside with the envelope and hands it back to him and says, oh, we can't get that to her. She has a DPOA and they wouldn't want us to give that to her. Now, there's all kinds of rights violations there, but my first one that I had to ask was, how did you know what was in the envelope? Why were you getting into an envelope? Why were you doing that? You can't do that. Or mail, and sometimes it is. We have sometimes where I've had to have a meeting. I had a person who, again, they were DPOA, but the person who they had the DPOA, the person had, they shouldn't have been making decisions yet in any fashion. The person can make their own decisions. And they found out that the DPOA had asked the operator to not deliver the mail to the woman. It's like, well, no, you have to just give her mail. And then the person decided, had to call and be very upset because they said, well, but she buys magazine subscriptions. It's like, well, she has the money to buy magazine subscriptions. Yeah, but she doesn't need that many. Well, it's not up to them. It's not up to them. And it's not up to them to know how many magazine subscriptions she even was buying in the first place. That's what I'm like, how do you even know this? Or I had a daughter call and she was really upset because she was afraid her mother may get kicked out of the nursing home because she was not being compliant. She kept asking for another piece of pie and she's diabetic. And I said, well, she has a right to have a second piece of pie if she wants that piece of pie. But I'm almost more concerned why you really even know about that. What prompted the nursing home to call you about a second piece of pie? Now, they do have an obligation to let loved ones know about important matters. And then they sometimes fail to do that. What we want them to do is inform them in the matters that are important and they should be informing loved ones about. That's important. Whether or not the person occasionally asks for a second piece of pie, it's her right. And she has a right to privacy in those things too. Telephones. They can't make a person use their own cell phone. They do have to provide a telephone in a private place. So making someone come up to the front counter or to the nurse's station is not okay. Figure out how to get a telephone in a private place for the person to have private communication. That's a right. All of these things. Don't leave the door open. Don't let someone walk in the door when you are providing care. If I'm walking down the hallway and the door flies open and someone is they're not clothed, and it's not by their choice that they're not clothed. That's another issue sometimes that happens. Sometimes people do want to not be clothed in a nursing home, but that's a privacy issue. That's a privacy violation that they should know to have things set in a way where they would not be exposed. That's also a dignity and respect issue. Some of these things, it's kind of hard. We'd be happy to have regulators look at it from either aspect. And sometimes it's hard to figure out which one to push more for. But any kind of anything, written, telephone, whatever, right to privacy. That means that when we hear something, when we're visiting and we hear the rustling in that bathroom in between two rooms, that a lot of times the resident and us look at each other and we kind of wink, and I'll ask, I'm like, is that your roommate? And they're like, my roommate are your in the Jack and Jill. So there's two rooms and a bathroom in between that they share. And I don't know how many times this has happened, that you hear something going on in the bathroom and you ask, you're like, and you may have gone past, that room may have been vacant. That room may have had someone in it that was in their bed and probably wasn't getting out of bed and going to the bathroom on their own. And I can remember so many times, but I can remember one gentleman that almost every time I would visit him, and he was one that would file a lot of complaints, and we would help him do that. And he would advocate for other people in the building, but he had a roommate that couldn't get out of their own bed. So we knew that the roommate wasn't in that bathroom, right? And so we kind of just got to the point where, he would take his wheelchair over and he'd just open the door, and there would be a staff person over and over again. They shouldn't be in there eavesdropping when they have a visitor. They weren't cleaning the stool. I don't know why they were standing in this bathroom. Shouldn't be taking a break in there either, quite frankly. So right to privacy, if you want to move on, because that one happens just a lot.
Before we do, we did have one question, and the question is, should a resident's durable power of attorney be recognized by facility staff as the resident's voice if the resident is nonverbal?
Well, nonverbal and not being able to communicate is two different things.
This is specifically nonverbal, like they cannot speak.
Okay, so they can't speak. So they still can communicate, though, perhaps in other ways. So are they able to write their wishes? Are they able to, and it depends on the issue. Okay. So there's some things that a person would be able to make very clear what their wishes were, whether or not they used words to speak or not, but unable to communicate at all, then the durable power of attorney probably would be enacted and then in place, inactive. So, and I may be using the wrong term exactly on that, but the durable power of attorney then would be looked at for their voice. Now, a durable power of attorney, and this is another whole training that we could do differently, but that durable power of attorney still should only be acting in the sense that they would have, in the way that the person would have. So if there's history to show that a resident wanted a certain thing, a certain way, just because they couldn't say it anymore really would not mean that the durable power of attorney should start changing what that person's life preferences were. So that's a little different than that. But no, they should honor what the durable power of attorney is saying the person's wishes would have been. Yes. Hope that makes sense.
I believe so, yes.
Okay, all right, thank you. The right to raise grievances. Wow. And this is something that is expressed to us often, is that people will talk to us about a problem. And sometimes we talk about the fact that ombudsmen are not therapists, but sometimes we are therapeutic. And that is because they still are afraid to express a concern or air a grievance, but they do have at least some validation by us talking to them about, yeah, no, that is your right. You are right. That should not be happening, or this should be happening. And they have validation. You can do that as a family member, as a caregiver, too, that for your loved one. You can, you can validate their feelings about whatever's happening. The other thing is this. We are not allowed to make reports without the resident consent. If they expressly tell us not to, then we cannot. If they are not able to any longer make their own decisions, they don't have the capacity to do that, we can make reports on the caregivers or on the DPOA's, consent or guardians. We still encourage you do it directly. The regulatory folks will take it into the first line. You may have seen it yourselves. You know about it yourselves. What we often encourage is that you make that complaint. You can tell them that you've talked to the ombudsman about it. Make that complaint by email, CC the regional ombudsman in that area so they know we are aware of it too. And that's sometimes helpful. And we know to follow up on the complaint as well. We may or may not be able to communicate to you in detail. There's twists and turns to that. If we can, we will. If we can't, we can't. But having us know about it is a good thing to do, and you're making it directly is a good thing to do. Whether or not,
take it a question, is that same for reports of abuse as well?
Same for, yes. So if the abuse, neglect, or exploitation or other matter that is not, is not the regulatory issue, whatever the issue might be, these rights issues, right? So you make the report to KDADS if it is about staff, someone that is working for the facility. If the issue is from someone who is coming in from the outside, who lives in the community outside and does not work for the facility, then the report goes to Adult Protective Services, APS. But if you give it to one or the other, they will get it to the right one if you perhaps are a little confused about which one it needs to go to. And we can help you sort that out too, if you do talk to us.
The next question is just going to the reports of abuse. So in the idea that you cannot make a report without the consent of the resident, does that mean that you are not a mandated reporter of abuse?
Correct, we are not. In fact, we are not only not mandated, we are prohibited from reporting without consent. With consent, we absolutely will assist that resident in reporting, however they choose to, whether they have us do it. I can tell you that sometimes the regulators don't like it when we do it directly, but if that resident asks us to, that is what we do. So we do whatever the resident asks us to do. So, and it is really important to know the distinction. It's probably a good idea to do both. Because again, we do follow up on now if we see abuse, we have there are a few different things that we can do. And for one thing is, if we're in a facility and we see it and we see another staff is around there and they see it too, we make sure that we remind them that they indeed are mandated reporters, and that while we cannot report it, we will be checking to make sure that a report was made. So what we would do in that case is we would get a hold of the regulatory agency. We say, hey, by the way, we need to know if you have had a report, the nature of the report during this time frame, and make sure. And if not, then we may go back to the person that wouldn't give us consent in the beginning and talk to them about getting consent to then report other things as well. And usually you're successful in doing that, quite frankly. The fact that we'll follow up and that we had honored them in the first place to not do it usually builds trust for them to let us help them in some other way, or to do it where we don't say the resident's name. We can get their consent to report but not use their name, which it makes it harder for anybody to investigate, but we can do that. So
awesome, thank you, that was very helpful.
Okay, you go to the next one. I think the right to access. So really, it is the resident's choice. I mean, it doesn't seem like it this last year with COVID and some of the things, we have been amazed as ombudsmen how even the federal guidelines have not recognized, quite frankly, residents' rights well, or they believe they have. They believe they have given the facilities the correct guidance to be able to make sure that residents are choosing what is happening, but we find that is not necessarily how that has been always interpreted by the facilities. But they have the right to choose whether or not they are in the building, out of the building, who they see, who they don't see. And so we also have this happen sometimes. It's normally in cases we do oftentimes have where we get contacted and it's like, we have one family member that says they don't want this other family member to visit. And it's like, well, It is up to the person to decide whether or not they have that visitor or don't have that visitor. And we've had people, quite frankly, again, we're talking about where they have a hard time, the ability to communicate is difficult. You can see through people's verbal, nonverbal expressions or communication, if they are distressed or not. We have at times gone out and actually been the ones that are the observation of, look, that was a very pleasant visit. They obviously want to see that person, you know, whether or not they could communicate with words or not. And so they get to choose that. Another time that I was thinking about is we had a few years back where Human Rights Watch, a worldwide organization, was looking at the use of psychotics in nursing homes. And they wanted to come in and talk to some people in nursing homes. And so they came into our state. They had visited 2 states prior to that. And there was an attorney that was going around our state and was accompanying us. And I know her and I went into the first home in Kansas together. And the very first home, we were met at the door by an administrator who had said they had received instructions, and I won't say where from, but they had received instructions that they were to prevent us from having her talk to residents, that they would prevent the human rights people, that they wouldn't be able to do that without, you know, getting permission for that. And I kind of smiled and I said, well, actually, they have a right, the resident has a right to choose their visitor. And I said, I'm here for 2 purposes. I am here first to make sure if they want to have this person visit with them, they will. And if they say, no, they do not want to talk to this attorney, they will not. And I'm here for both purposes, because we are their advocate and we will make sure that they get to choose whether they do or they do not have that visitor. A person can refuse to have their guardian visit them. That's crazy, but it's not in some senses, because in any given day, you know, my son or my daughter might want to talk to me and they might not, and we get to choose that, right? Well, to some extent, not when we're, you know, small children, unfortunately, but for the most part, these are adults and they get to make adult decisions. So their personal medical records, they have a right to those. They can make a verbal request for those, and it should be honored within 24 hours at no charge to just visually see them. If they want copies of them, then they have 2 days to get those to them, and there can be a charge associated with them. Typically, a home will not charge for, you know, 1 or 2 sheets of paper, but if somebody's requesting extensive documentation, they can charge for those. And sometimes we do get in the middle of that because they may try to charge excessive amounts, and it should be a reasonable, you know, the same thing the library in town's charging or some other governmental entity. So that's kind of how we, and that's how it's worded and expected too. I had another question there. What was the question? I didn't see it before.
To what lengths must the facility go to protect the resident from a visitor who makes them feel unsafe or threatened?
Well, so the person themselves says, like you or I would, I want you to leave. This is my home. I want you to leave. So if they're saying, I don't want you here, then the facility has an obligation to say, they've asked you to leave. You'll need to leave now, or we will have to call someone to help that happen. But the person needs to say it. You know, and so we sometimes, I can't tell you really how many times that we get called to say that someone feels unsafe. And when we go out and meet the person alone, they either don't express any fear at all, or they actually then talk to us about the facility not wanting that person to visit because that person's been advocating for them or something like that. So it's really important that we get to the bottom of visitors, and they can change their mind. So I don't want you to visit today, but I want you to visit the next time you come. They get to make that choice every time, just like you or I do when someone knocks on our door. Okay. But they do have an obligation to protect them. If they're saying, no, I don't want you here, they do actually have an obligation to ask them to leave. And if they do not leave, I will have to call law enforcement, is an appropriate thing. We've helped over the phone before. I couldn't get, I didn't get, we pulled into a phone conversation, and the resident was very, very, very upset. And she had asked someone to leave multiple times. And the social services person was not comfortable asking them to leave. And I was on the phone, and I said to the resident, I said, Mrs. So-and-so, I said, do you want us to ask them to leave? And she said, yes, I want them out of here now. And so they were in the room, you know, and I asked, I said, I'm going to have to ask you one time now to leave. And I said, if you do not honor her request, I'm going to have to call law enforcement and have them come to the building. And the person immediately left. It's really just a matter of communicating well. And it's like, she may decide the next day she wants you to visit. That's okay. That's okay. We have a right. No means no for that too. So personal physician visits, access to anyone. In fact, it's a crime in the state of Kansas. It is a crime to not allow access by the ombudsman. I had a guardian this morning that was upset because our ombudsman had visited the facility and was talking to the resident, and the resident was talking about some of the things that they would like. And apparently it upset the guardian. They found out about it. Again, I'm not sure why, because they were supposed to have privacy and communication with their ombudsman. So I'm not sure how the guardian even knew that the conversation occurred. But the guardian called and threatened our office, quite a bit of different threats that she made to our office. She kind of said she didn't later, but I have them on voicemail. So I had to tell her about the interference to our office, and that they had a right to access their ombudsman, and that I would respect their right as the guardian and trying to do what was in the best interest of the person that they're trying to serve, but to understand that our hat as an advocate to these people to have the rights honored, and that we would continue to visit as long as that person wanted us to. So they have that right to access, and their physician, the state survey agency. I know for our visitation, when we started visitation back up, we were told that we may have some trouble getting into buildings. We have had no trouble getting into buildings, and we greatly appreciate that. It is recognized by the buildings that we indeed do have access to be able to make sure that people can talk to us. And so we've had no problems with that. But I did meet with multiple legal entities ahead of time too, to make sure that should we have any trouble with access, that that would be honored and taken care of, in the same way that someone can ask someone to leave and we might have to call law enforcement, that we would indeed call law enforcement if we were not provided access. So people have a right to their social, religious, community gatherings. And if you want to go to the next page.
And Camille, it looks like we are just about at time. So
okay, and right, transfer discharge. You know what? Margaret is well capable of covering discharge and transfer rights, and they do. They have all kinds of rights. There's very limited reasons why people really are allowed to. What they don't have in a state licensed homes are appeal rights, and we hope to have that happen in this next legislative session. So we're going to support that. I know KABC has got that that they're working on. So thank you very much for your time.
thank you so much, Camille.